So a large number of these cells, hello, hello, hello.
Hi.
Is there this thing obstructing?
We are okay. Everything is okay.
Okay, all right. So a large number of bound cells and segmented neutrophils are held in the bone marrow as a reserve pool or in a storage compartment. So there's a ratio of 2:1 or 12:1 of myeloid cells to erythroid cells. That is, myeloid cells outnumber the erythroid cells in the bone marrow. In a stable, normal state of the bone marrow, it contains about 10 to 15 times the number of granulocytes found in the peripheral blood. There are two pools, usually of equal size, in the bone marrow. That is circulating pool that included blood count that is seen in the peripheral blood, and then marginating pool. So we have circulating pool that is in circulation, and then marginating pool that is usually reserved in the bone marrow. It has been estimated that an average of 4 to 5 days, it has been estimated that they spend an average of 4 to 5 days in the tissue before being destroyed by defensive action or as a result of senescence. Senescence is more or less programmed cell death. So it's been programmed that when they spend 4 to 5 days in the blood or in the tissue, then their life has come to an end. So we'll take a look at the various categories of granulocytes. The first is, hello, hey, hello.
Hi.
Are you with me?
Yeah.
In fact,
Yeah.
when you say hello 2 to 3 times and you don't hear anything, it's as if
you don't
you
hear
are only here talking to yourself.
That's the way it is. Tell them for me. Tell them for me.
Oh, Charlie, it's serious.
Tell them for me. Tell them for me now.
And when you can't spend all the time then talking to yourself, eh? So we need to show some distance.
That's why. So we have to sometimes put it on before we can respond. So sometimes that's why we delay.
Okay, all right, agreed. But let's do it fast so that we don't.
You can quickly unmute and say something like I do.
That's it. So neutrophil has a characteristic dense nucleus consisting of between 2 to 5 lobes. It has a pale cytoplasm with irregular outline. It contains many fine granules such as azuropheric or gray-blue granules. There are two types of granules in the which are lysosomal. There are two types of granules which are lysosomal. So the primary and the secondary. The primary appear at the myelocytic stage. That is, the granule contain myeloperoxidase, acid phosphatase, and other hydrolases. And the specific granules, that is the secondary granules, which appear at the myelocyte stage and predominate in the mature neutrophils. They are basically collagenase, lactoferrin, and lysosome. The lifespan of neutrophil in the blood is about 6 to 10 hours. 6 to 10 hours. So let's look at how does neutrophil come about in the blood system. So the first precursor cell of the neutrophil series is myeloblasts. Myeloblasts also differentiate into other cells. So we'll see that one shortly. So it is the earliest recognizable precursor. It is the earliest recognizable precursor. It's a cell of variable size. It has a large nucleus with fine chromatin. It has 2 to 5 nucleoli, basophilic cytoplasm, no granules in the cytoplasm, and normal bone marrow contains about 4% of cells in the bone marrow are myeloblasts. So from myeloblast state, we get to promyelocyte. Promyelocyte is slightly larger cells compared to the myeloblasts, develop primary granules in the cytoplasm. Then from promyelocytes, it develop into myelocytes, which have specific or secondary granules, more condensed chromatin, nuclei are not visible. So from the myelocyte stage, it developed into metamyelocytes. Metamyelocytes are non-dividing cells, have an indented or horseshoe-shaped nucleus. Cytoplasm is filled with primary and secondary granules. Okay? Then come to mature neutrophils. So neutrophils form between metamyelocytes and fully mature neutrophils are called born, stub, or juvenile cells. Okay? These cells may occur in normal peripheral blood. They do not contain the clear, fine filamentous distinction between nuclear lobes that is seen in mature neutrophils. So, are you following the discussion, please?
Yes, please.
Yes.
Yes. Okay. All right. Thank you. So we may see, let's see, some benign disorders of neutrophil. A number of hereditary conditions may give rise to changes in granulocyte morphology. First being Berger-Waite anomaly. This is a common condition.
Hello, boss.
Hello?
Please, may I please make some clarification before you continue?
Okay, okay.
All right. Yes, the previous slide.
Okay.
I want to find out after metamyelocytes. I know of
Okay.
also band neutrophils.
Yes.
Is it same as the band stab as you mentioned here?
It's here, is in the thing. It's a neutrophil formed between metamyelocytes and fully mature neutrophils are termed band, stab, or juvenile. Do you get it?
Okay.
All right. And these cells may occur in normal. These cells may occur in normal peripheral blood. Okay. Are we there?
Yes, please.
Okay. Thank you.
So it was the terminology that I needed to clarify.
Okay.
I'm
Okay.
used to
All
the
right.
term band neutrophil, and I'm
Okay.
seeing band stab. So I wanted to clarify that terminology.
Okay. All right. Thank you.
You're
Thank
welcome.
you. So we are looking at some benign disorders of neutrophil. Just as I said, the first that we may look at is Berger-Waite anomaly. Okay, this is a common condition in which bilobes neutrophil are found. Bilobes neutrophil are found in the peripheral blood. Occasionally, unsegmented neutrophils are also seen. It is autosomal dominant inheritance. Okay? And the second one we may find is Mehaglia anomaly. This is a rare condition in which neutrophils contain mesophilic inclusion of RNA resembling dual bodies in the cytoplasm. There's an associated mild thrombocytopenia with giant platelets. It is also the dual is it has variety of spelling. There are some which is O with double dot on top, and those that do not have O double dot, it is A. So it's the same thing that we are looking at. So it is also autosomal dominant in inheritance. Okay. And the other benign disorder we may come across is Chidiac-Higashi. Okay, Chidiac-Higashi. It is autosomal recessive inheritance, giant granules in the neutrophil, eosinophil, monocyte, and lymphocyte, accompanied by neutropenia, thrombocytopenia, and MAC hepatosplenomegaly. And another benign disorder that we may come across is Halley syndrome, or Halley, or whichever you pronounce it, or wherever you come from. It is abnormal leukocyte granulation or vacuolation, also seen in patients with rare macropolysaccharide disorder. Okay? So some common morphological abnormalities that we may see. This is basically hypersegmented neutrophils that is seen here. We may come across dual bodies very soon, and the rest. Okay? So neutrophil leukocytosis, as I said, yes, as I said, dual body. That is it. It's compact nucleus with these granules in the in the cytoplasm of the cell. Berger-Waits anomaly. This is Wurtz clamping or the chromatin in this one. I don't know what it is. I don't know whether it's French word or English word or whatever it is. With business configuration. So our French brothers in the class can help us whether it's a French word or not.
It's a French word.
Okay, all right.
More or less like a pointed nose. Okay,
all right. Thank you. So Shidia-Higashi syndrome, that is what it is, with these giant granules in the cytoplasm, bizarre giant granules in the cytoplasm of monocytes. So you can see the granules in here. Okay. Other anomaly was violent granulation in the cytoplasm of neutrophil. You can see the granules here in the cytoplasm. So what causes increase in neutrophil population in the blood system? So an increase in circulating neutrophils to a level greater than 7.5 times 9 to the power times 10 to the power 9 per liter is more frequently observed blood count changes. Neutrophil leukocytosis is sometimes accompanied by fever as a result of leukocyte pyrogens. Okay. Other characteristic features of reactive neutrophilia may include shift to the left in the peripheral blood differential white cell count. That is increase in the number of band forms and the occasional presence of more primitive cells such as metamyelocytes, and myelocytes. It may also occur as a result of presence of cytoplasmic toxic granulation or DOE bodies and elevated neutrophil alkaline phosphatase score. Are you with me, please? Hello?
Yes, please.
Hello?
Yes, please. Yes, we are with you,
Yes,
sir.
we are following.
Okay, all right. Should we continue?
Yes, please.
Please, if you can throw more light on the alkaline phosphatase score, it's a new thing to me. So,
Okay, we'll to that when we get there. When we get to that place, particularly Lukemia reaction. So Lukemia reaction, there is a alkaline phosphatase score that is used to differentiate Lukemia reaction and leukemia. So when we get there, remind me so that I'll throw more light on it for you to understand.
okay, thank you.
Thank you too. Okay, okay, it's here. Okay, Lukemia reaction. Lukemia reaction is a reactive and excessive leukocytosis, that is increase in the number of leukocytes, usually characterized by the presence of immature cells. For example, myeloblasts, promyelocytes, myelocytes in the peripheral blood. Okay? Occasionally, lymphocytic reaction also occur. It's also associated disorder. Also associated disorders include severe or chronic infection, severe hemolysis, and metastatic cancers. Okay? Lukemia reaction are often particularly marked in children. In children, that is when they crawl on the ground, they eat anything that they come across. And this stimulates a reaction in them. So that is where Lukemia reaction is particularly marked in children. So granulocyte changes such as toxic granulation or DOE bodies and a high NAP score help to differentiate between Lukemia reaction from CML. In CML, the Lukemia reaction, in CML, the NAP score is very low. But in Lukemia reaction,
Hello,
the
Doc.
alkaline phosphatase score is very high. Hello?
Hello, Doc. Yes, Doc.
Hello? Yes?
Yes. In a school of thoughts,
Yes?
I also read something on the Lukemia reactions, which
Okay.
come as some medications will also
Yeah.
be part of it, like the steroid.
Exactly.
It's also
Yes.
and some disease condition like arthritis,
Uh-huh.
also, and then rheumatoid arthritis.
Okay.
Is also involved in,
Yes.
and then pneumonia also
Okay.
involved in, and then sepsis, yes, also cause leukemoid reactions.
Okay. That's correct.
Thank you.
That's correct. So in order not to confuse yourself, in order not to confuse anybody, then you do the neutrophil alkaline phosphatase score, for which if it is chronic myeloid, CML, the score will be very low. But when it's leukemoid, then you have a high score. It is scored between 0 and 4. It is scored between 0 and 4. So when it's leukemoid, it's getting to 4 and above. But when it's CML, you have it to be closer to 0 or none at all. So that is where we are. So causes of neutrophil leukocytosis. Bacterial infection, as we always know, is one cause. Inflammation is another cause. Metabolic disorders is another cause. Neoplasm, such as carcinoma, lymphoma, melanoma, are all they all cause neutrophil leukocytosis. Acute hemorrhage or hemolysis can also cause neutrophil leukocytosis. Drugs such as corticosteroid can also cause that. Lithium and tetracycline can also cause. Then we have chronic myeloid, CML, as we always know. Then myeloproliferative disease can also cause neutrophil leukocytosis. Polycythemia vera, myelofibrosis, essential thrombocytopenia. Essential thrombocytopenia. It may interest you to know that all these myeloproliferative diseases, or CML, polycythemia, and essential thrombocytopenia cannot transform into acute lymphoma. Acute leukemia, not lymphoma, acute leukemia. Acute leukemia. Okay? Then sometimes treatment with myeloid growth factor can also cause neutrophil leukocytosis. Some inherited diseases can also cause lymphocytosis. And then we look at if it's low, that is.
Hello, sir.
Yes.
Please, on your previous slide.
Hello?
Hello.
Yes.
Yes, on your previous slide, I heard you mention the essential thrombocytopenia. But I think the orthograph there is not thrombocytopenia.
Essential thrombocytopenia.
So the spelling,
Thrombocythemia.
okay.
Cythemia.
Okay.
Thrombocythemia.
Thrombocythemia.
Yes.
Okay.
Essential thrombocythemia, not penia, it's tinea. Okay. All right. Thank you.
And then the previous one too.
Which one? Previous slide.
The one before this one.
Okay, wait. Oh, yeah.
Yes. So the last paragraph at your right. So the granules changes in the toxic granulation diol bodies. Is it seen in leukocyte reaction or is seen in chronic myeloid leukemia? I didn't get it.
Hello. I can't hear you well.
Yeah, he said that part.
Come again.
Your last paragraph at the right
Okay.
side. Yes, where you
Oh,
said
this one,
yes, yes. So I'm
uh,
asking to know whether the toxic granulation and then the diol bodies, whether they are seen in Licomer reaction or they are seen in chronic myeloid leukemia.
you see, you can see both of them. You can see both of them. You can see them both in that reaction. That is where the neutrophil alkaline score is very important.
Okay.
So you do the NAP to differentiate whether what you are seeing is actually Lukemore reaction or CML. Do you get me?
Okay.
All right. Thank you. So causes of neutropenia. So we have selective neutropenia, that is congenital. Cosman syndrome, I don't know what it is, but that's what the book gave us. So acquired will be, hello? Huh? My boss. Alote. Miss Alote. Miss Alote. Okay, so we have a congenital acquired. Acquired is drug-induced anti-inflammatory drugs. That is phenobarbital can also cause neutropenia. Antibacterial drugs such as chloramphenicol, cotrimazole, and the rest can also cause that. Anticonvulsant such as phenytoin and the rest can also cause that. And then antithyroid such as carbimazole can also cause low neutrophil in blood circulation. Then hypoglycemic drugs can also cause that. Psychotropic and antidepressants can also cause neutrophilia. And miscellaneous are gold and the rest. Furosemide and then penicillamine, all can cause neutrophil count to be low. Okay. And then we have a benign, that's racial or familial. So immune disease such as autoimmune, SLE can also cause hypersensitivity, or anaphylaxis can also cause that. Large granular lymphocytic leukemia can also cause neutrophil value to be low. Infection such as viral diseases such as hepatitis, influenza, and HIV can all have influence on neutrophil counts in the blood system. And then some other things like, I call it military tuberculosis, all can result in low neutrophil count. Bone marrow failure, as we know, can also cause that. Splenomegaly can also cause that. Okay. So let's look at another series, that is monocytes. Monocytes are usually larger than any other peripheral blood leukocytes. It possesses a large central oval, a dented nucleus with clamp chromatin. It has abundant cytoplasm, stains blue. Okay. Then it has many fine granules giving ground glass appearance. Cytoplasmic granules are also often seen or present. Very difficult to distinguish between monocyte and myeloblasts. That is, it depends on your experience. They spend only a short time in the bone marrow. They circulate about 20 to 40 hours in the peripheral blood, leave the blood to enter tissues where they mature and carry out their principal function. Okay? So this is how it is. Myeloblasts here, myeloblasts, which can differentiate into neutrophil and neutrophil precursors, and then it can also differentiate into monocytes and monocyte precursors. So to differentiate into promyelocyte, myelocyte, metamyelocyte, bound neutrophil, neutrophil, and then continue. Okay. Then the other way is when it differentiates into monoblasts, monocyte, not monoblast, monocyte. It forms myelomonoblast. Myelomonoblast is the first precursor cell. Then monocyte, and then it comes into the blood circulation as monocyte, and then enter into the tissue as macrophage. Okay. So many growth factors, including interleukin 1, 3, 5, and 6, all act on this cell to cause it to differentiate. Okay. And then other factors such as microcyte colony stimulating factor also act on it. Granulocyte colony stimulating factor and monocyte colony stimulating factor all act on this cell to cause it to differentiate to monocytes. Okay. So these growth factors stimulate production, proliferation, and differentiation of these cells, and also affect the function of the mature cells in which they act. So all these growth factors, interleukin 1, 3, 5, and 6, GM-CSF, GCSF, MCSF, all act on this cell, this precursor cell, and differentiate into monocytes. So all these growth factors help in the differentiation of this cell into monocytes, for which when they circulate in the peripheral blood and then enter tissue to continue with their function. Okay. So when monocyte in the peripheral blood, this is monocyte. When it gets to kidney, it is called intraglomerular. Hello? Hello?
Yeah, we are listening.
Okay. So these are various names. These are various names of monocytes, or more or less macrophages in the various tissues. They don't have the same name when they enter into the tissues. So these are the names of the cells when they enter into the tissues. Then again, causes of monocytosis. Chronic bacterial infection, such as tuberculosis, brucellosis, bacterial endocarditis, and typhoid can all cause monocytosis. Connective tissue diseases such as SLE, temporal arthritis, rheumatoid arthritis can also cause monocytosis. Protozoa infection, as we know, particularly are well-known and well-documented malaria parasite can also cause that. Then chronic neutropenia. Chronic neutropenia can also cause this. And then Hodgkin disease, and acute myeloid leukemia, and other malignancies. Myelodysplasia, particularly chronic myelomonoclonic monocytic leukemia, all can cause monocyte population to be increased in the peripheral blood. So eosinophil is one of the white cells that we are dealing with. So this cell is similar to neutrophil. It has a large coarse cytoplasmic granules, more deeply red staining, really more than 3 nuclear lobes. It has occasionally it has 3 nuclear lobes. So blood transit time for eosinophil is longer than that of neutrophil. Okay? It enters into inflammatory exudates, have a special role in allergic reactions, defend against parasites, and removal of fibrin formed during inflammation. Okay? My picture is not clear. So sorry, the picture is not clear. Otherwise, you would have seen the lobes. The lobes we can see the nucleus. But the granules, we can't see the granules. We can't see the granules very well. Okay. So eosinophilia is cause of an increase in blood eosinophil above 0.4. 0.4. Hey. Who is that?
It's from your side, though.
No. Okay, all right. Let's continue. So this causes an increase in blood eosinophil above 0.4 times 10 to the power 9 per liter. Sometimes no underlying cause is found. And if eosinophil count is elevated, more than 1.5 over 6 months and associated with tissue damage, then hypereosinophilic syndrome is diagnosed. It's very unfortunate that we cannot see the granules as it is here. Okay. So causes of eosinophilia, allergic reaction, as we know, hypersensitivity to tropical types such as bronchial asthma, hay fever, urticaria, and food sensitivity are all causes of increased eosinophilia in the blood system. Parasitic infection such as hookworm, ascaris, tapeworm infestation, filariasis, schistosomia, and the rest. They are all potential candidates. They are all potential candidates for eosinophilia. Recovery from acute infection. Recovery from acute infection is also a candidate for eosinophilia. Drug sensitivity. Drug sensitivity. Graft versus host disease. Hello. Hello.
Yes, we are
Hello.
here.
Okay, all right.
Hi.
Okay, that's okay. Certain skin diseases are all candidates for increase in eosinophil count in the blood system, in the peripheral blood. Okay? Hodgkin disease and some other tumors, especially T-cell disorders. Okay? This one, I think I've repeated it twice. Some tumor necrosis, hypereosinophilic syndrome, I've mentioned it already. Chronic eosinophilic leukemia, myeloproliferative disease, including systemic mastitis, are all candidates. Pulmonary syndrome, such as eosinophilic pneumonia, all these ones are all candidates for increased eosinophilia reaction in the peripheral blood. Next in line is basophil. These are occasionally seen. It is occasionally seen in the peripheral blood. There are many dark cytoplasmic granules which overlie the nucleus and contain heparin and histamine. In the tissue, they become mast cells. They have immunoglobulin E attachment sites. Degranulation is associated with histamine release. Degranulation is associated with histamine release. Basophilic leukocytosis, that is basophilia, has an increase in the basophilic number from 0.1, 10 times 10 to the power 9 is very, very uncommon. It's usually the usual cause is myeloproliferative disorders such as CML or polycythemia vera. Then we have a reactive basophilia increase are sometimes seen in mesothelioma during smallpox or chickenpox infection and ulcerative colitis. And these are smallpox and chickenpox are viral infections. Okay. And a very important cell among all the white blood cells that we are talking about is lymphocytes. Lymphocytes are immunological competent cells that assist phagocytes in defense of the body against infection and other foreign invasions. Two unique features, characteristics of immune system are the ability to generate antigenic specificity and a phenomenon of immunological memory. So lymphocytes have antigenic specificity that help in the body immunological system, and has a memory that it can remember a lot of things that is happening to the body and keep that in memory. So leukocytosis is often occurs in infants and young children in response to infection that produce neutrophil reaction in adults. Is because infants, because they crawl on the ground, so they pick any item that they come across, put it in their mouth, swallow or chew. So this is as a result of producing some lymphocytosis in children and infant and young children as a result of that crawling habit. So we can see from here, it has a large nucleus with a very thin cytoplasm. Okay. So you can see, you can compare it to the size of the red cells. Usually when you are doing foam comment, you compare the size of red cell to small lymphocytes. So this is a typical example of what we are doing. So we compare the size of this red cell to the size of these lymphocytes. Okay. This is a very reactive lymphocyte. So it has irregular nucleus and irregular cytoplasm. All are very enlarged. That is why it is called reactive lymphocytosis. Okay. Then here we have a large granular lymphocyte. You may see the granulation in the cytoplasm of the cell. Here they are here. And then the nucleus is also very large, and then there are granulations in the cytoplasm. Okay? So let's look at what is the cause of high increase of lymphocytes in the system. Okay, so we may have infection. Infection are categorized into two: acute infection and chronic infection. So acute infection, such as infectious mononucleosis, rubella, pertussis, mumps, acute infectious lymphocytosis, infectious hepatitis, and cytomegalovirus, HIV, herpes simplex, or Zika. They are all causes of increase in lymphocyte number in the peripheral blood. Then we come to chronic infections such as tuberculosis, toxoplasma plasmosis, brucellosis, syphilis, CML, AML, non-Hodgkin's lymphoma, some types, and thyrotoxicosis are all candidates for high increase of lymphocytes in the blood system. Granular fever is general term for a disease characterized by fever, some truth or lymphoadenopathy, a typical lymphocyte in the blood. So they are all candidates in the in lymphocytosis. Some viral diseases such as EBV, the Epstein-Barr virus, cytomegalovirus, human HIV, or toxoplasma are all candidates for lymphocytosis. Okay, so after looking at all these things, we may have the option of looking at what is their number and why do you say neutrophilia or eosinophilia or neutropenia and the rest. So these are the blood count, number of cells in the blood, for which you may use to categorize whether it's increase or decrease. So total lymphocytes is between 4.0 to 11.0 times 9 times 10 to the power 9 per liter. Okay? That is in adults. So lymphocytes in adults is 2.5 to 7.5. Eosinophilia is 0.04 to 0.4 times 10 to the power 9 per liter. And then monocyte is 0.2 to 0.8 times 10 to the power 9 per liter. Basophils, 0.01 to 0.1 times 10 to the power 9 per liter in the blood. The lymphocytes, this is 1.5 to 3.5 times 10 to the power 9 per liter. All these are absolute counts. Absolute counts. Then we may come to in children, that is neonates. Neonates tend to have a higher leukocyte count peripheral leukocyte count, that is 10 to 25. Okay, then a year, 1 year, you may have 6 to 18 times 10 to the power 9 per liter in the blood. The 4 to 7 years is 6 to 15 per liter in the blood. Then 8 to 12 years, that's getting to adult level. Okay, so that is 4.5 to 13.5 times 10 to the power 9 per liter. So this is a caveat. This is a caveat. Normal blacks and Middle East subjects may have lower counts. Okay, in normal pregnancy, upper limits are so you don't necessarily have to do pregnancy test to tell whether somebody is pregnant or not. You can even look at the WBC and then the neutrophil count to say this lady is pregnant or whatever it is. So that is from experience, not a novice. A novice cannot do this judgment. It's from experience, high experience. So that is it. Okay. So we've done. It's about 8 minutes to 9. 8 minutes to 9. So we've come to the end of our presentation. So question and answers. Questions, and I'll try and give you answer as it is. Hello.
Hi, we are with you.
Okay, all right. So let the questions flow.
Your last slide where you
Okay.
display the reference ranges.
Okay.
Yeah, so the children portion, I believe what you presented is only for the total WBC counts, that the reference ranges that you stated for children with the age category.
Yeah, yes, please. Yes, please.
Oh, okay. Okay.
All right.
Thank you.
Thank you too.
But I can see that there's a gap, for instance, between 1 to 4 years. So which one should we use?
There's no gap. 1 year is 6 to 18, and 4 to 7 is 6 to 15. Okay.
So if a child is 2 years or 3 years, that is where my concern is.
is once it's below 4 years,
Okay.
the range for 1 year here is applicable. Okay,
All right,
the range for this year is applicable.
Okay, thank you.
Thank you too. Hello. Hello.
Hello, Doc. We are with you.
Yes, come. Ask your question.
It's just that our school have won the Science and Brilliant quiz today.
Which
so we
school?
are halfway.
Which school is that?
So we are celebrating.
Which school is
Fanti-
that?
MOBA.
Huh?
MOBA.
Oh, Uvasipim.
Yes, please.
Kwaboche.
Yes.
Oh, that's
Sharp
great.
guys. Sharp guys.
Ah. Oh, that's great. That's great. That's great. That's great. That's very, very wonderful.
This one is back to back. Back to back.
Back to back. Back to back.
No one can challenge us. We are always other schools are all made from China people, so they are not the best schools.
That's great. That's great. Question, please. We have 4 minutes to 9 o'clock, so more questions. In fact, I've taken pictures of some slides that I want to show, but in fact, I'm handicapped because I don't know what I'll do, and this screen will disappear. That will give me another headache to bring it back. That's why I'm reluctant to share those slides with you. But let me try and see. Okay. Can you see this slide?
Yes, please.
Yeah.
Okay. This accounting, this is a Nuba counting
The best chamber.
chamber. This is what you use in counting WBC in the bloodstream. Before analyzers, this was what we were using.
Yeah.
So you count where the W is. You count the cells that is here and here. And this place is used to count platelets, thrombocytes. Okay. So yes, to whet your appetite. Just to whet your appetite about how you count. How do you count the cell and say this cell number is increase, this cell number is decrease? Is by employing technique from this chamber. Okay, so that is it. Let me see whether I can bring another one. Oh. Hello. In fact, my technology is not it's not easy, so I'm finding it difficult to bring other things to.
Add yourself to my generation. Don't add.
I'm finding it difficult to bring other things for sharing. In fact, we were to do platelet count. platelet count, but very unfortunately, we cannot have that this evening. But I'll talk to my boss, Mr. Alote, and we find appropriate time. Probably next Monday, I'll present on the on platelets, for which you continue with the rest of the presentation. So bear with us. Monday we'll do just that. We'll do a lot of presentation. That is if by what I have on my my timetable, we are left with only platelets. I think Monday presented on red cells. Today we are presenting on white cells. And then next week, Monday, I'll do a half session on platelets. Then he will continue with the rest. And then recapping. Then you summarize all that we have done so far and bring it to speed about the presentation. Hello.
Yeah, we are listening.
So that's it. So more questions. If you don't have any question, then you may call it a night. And then people who are enjoying will continue with their enjoyment. And those of us who go to sleep, will all go to sleep. Our Kwabuchi brothers, congratulations to you once more. You've done a good job. It was an excellent thing to do, back to back. Congratulations once again. Yes,
thank you,
please.
Doc. You live long.
Yeah.
You live long.
Yeah, that's it. You live long.
You live long. You live long.
Yes.
You live long.
The thing is that a lot of people do not know that Kwabuchi is a very old school and very good academically. So the rest can boast, but we have elders among the population. So that's it. So Latif, CPD consult. Oh, my boss, Salote. Salote.
Yeah, I'm here.
Please, if you have anything, share with us.
Oh, not much, but just to say what I have my take home. I mean, a little bit of my take home, so that colleagues would also think through and do their own take homes. From what we have been taught, the presentation has been very detailed. The take home number one for me is that when it comes to white cell pathologies, the first thing we have to think about are the numbers. And he has expressly told us about the numbers, the different types of white cells that we have, the numbers. So neutrophilia, neutropenia, etc., etc., etc. So the numbers, or if you like, quantitative. The next thing is qualitative. And I heard him very well talk about some benign disorders mentioning Pega-Hill anomaly, Shagia, Higashi, and rest of them. I even recall he talked about toxic granulations, Dolly bodies. He talked about cytoplasmic vasculation in bacterial infections. Those are things that we will encounter like very often. And then he talked about leukemoid blood pictures. He talked about the different situations that will come across leukemoid. And I recall the last time we talked about language, and leukemoid, the oil there means like. So it looks like leukemia, but it is not actually leukemia. So we must be able to differentiate what we call leukemoid blood pictures from leukemic blood pictures. And when it comes to determining whether wild cells are primitive, meaning they are supposed not to be in peripheral blood, these are the things that we consider. First of all, we look at what we call the nuclear cytoplasmic ratio. It has come up before, meaning that you're looking at the cell size plus the size of the nucleus. And in the primitive cells, the cells are described as having high NC ratios or high nuclear cytoplasmic ratios, meaning that there's a large cell and also there's a large nucleus. I'm trying to say this pictorially because these are the things that would want to see and determine a slide is having primitive cells or cells that are supposed to be in the marrow and not in peripheral blood. I recall he showed us in the case of the myeloid cell series from the myeloblasts through the promyelocytes, the myelocyte, the mesamyelocytes, the bound neutrophil, and then the mature neutrophils. He went through that. He went through the monocytes, the lymphocytes, etc., etc. And so, high NC ratio means that the cell is primitive. The problem we have here is that if you just take it like that, high cell monocyte. So the cytoplasm of the cell is deeply basophilic, deep blue. So the deep blue sets the immature cells apart from a monocyte, which cytoplasm is described as ground glass or grayish. And then the third thing, in the case of primitive cells, presence of nucleoli. As soon as you see the nucleoli or nucleolus, then you know you are dealing with a primitive cell. So numbers, NC ratio, color of cytoplasm, presence of nucleoli are the key things for us to determine whether a white cell is matured or not. In the case of the neutrophil, the number of lobes may also be a factor. And so that's a little I'm taking home from all that have been said. Apart from that, the conditions in which some of these things are seen have been mentioned. And so I am aware that colleagues are well informed when it comes to these things. So that's for me what I'm taking home.
Thank you. Thank you, boss.
So thank you.
Thank you too. Colleagues, our senior, Charlie, I give you much respect. You have just done a complete summary of what I presented this evening. And if you listen carefully to my boss Alute, what he has done is to recap all that we learned this evening, and very, 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 very articulate on those issues. So I thank you so much, my boss Alute. Any further question?
Hello.
Hello.
Yeah, please.
Oh, your network is not good.
The NAP.
Yes.
Yeah.
Like, how does it look like? How I said with the NAP, how is it done? Or how does it look like? Hello.
In fact, if I haven't done it before. Hello.
Oh, okay.
Yes.
So
My boss
like
Alute.
it is a staining technique. It is a staining technique. You see, it's a staining technique. There are regions that are available and instructions as to do it, but the reaction product is blue. It stains what they call the granulocytes, and they are granules. So
Okay.
especially neutrophils. So where you have a lot of mature neutrophils, you have a strongly positive reaction. If we decide to do cytochemical stains, we'll be talking about these things.
So like, how do we get the score?
If time would allow us, the stain is counting. I mean, it's a lengthy thing. There's a what you call it, ascribe score from 0 to 4, depending on the intensity of the coloration that you see. And so it's why pushing it back to say dealing with cytochemical stains and actually speaking to these things. Otherwise, it was just a general thing that I would say. And they will not be available for us to actually practice. Would have loved to do that. But these are not difficult things. If you have the reagents and the instructions, it can be done.
That means it's not really common in our system here.
Who says it's not common? We don't buy them. We don't buy them.
Okay.
We are using just what you call it, Romanowski stains to determine what is a leukemia and what is not.
Oh, okay.
That's the thing. That's the thing, because they are actually,
and they are not that expensive too.
Well, we used to have them in Korle Bu, as far as I know, but now I don't know. The what you call it, the myeloperoxidase, the Sudan Black B, the NAP, we used to have them.
Oh, okay.
What I know we never had were the esterases and the rest of them. But as for the PAS, the myeloperoxidase, the Sudan Black B, the NAP, they were available. And these are used to help us really identify the cells in the leukemias, the lineages. When it comes to the lymphocytes, we are stuck because you don't have immunophenotyping, because immunophenotyping is better for the lymphoid cells. And so when it comes to the lymphoid cells, we are stuck. We end up also still using PAS.
All right, that's wonderful. That's great. Any more question? Any further question?
No, please.
All right, thank you.
Yeah, this thing went off. That's why you didn't
Okay.
hear from me. I went
Okay,
off.
all right. Okay, all right. Thank you. Thank you for your explanation. CPD consult. CPD consult.
Yes, thank you, Dr. Degin.
Yeah.
Just to remind our participants, especially those who have not paid up their fees, to do so as soon as possible. We gave a deadline of end of last month for payment of up to 2,000 cedis, and then the balance should be paid by end of this month. So we'll be checking those who have not completed payment up to 2,000 cedis. We are likely to take them off the platform. We don't want to do that, but let's try our best so that we'll make this program a successful one. Thank you.
Thank you. Thank you very much. All right. So we may call it a night. So good night.
Good.